بسم الله الرحمن الرحيم. هنتكلم النهارده على موضوع مهم قوي بنشوفه كبيدياتريك orthopedist, which is idiopathic toe walking. What is the meaning of toe walking in general? It is absence of heel strikes. So at the start of stance phase, the heel does not strike the ground, and usually the striking point is the toes rather than the heel. So there is almost absence or lack of all rockers of the foot during the gait cycle. There are a lot of mixed terminologies in the literature that make some confusions. Some call it congenital short hand Achilles, others call it habitual toe walking, but now there is agreement to call it idiopathic toe walking. So what is the definition of idiopathic toe walking? Idiopathic toe walking is all cases in which children walk on their toes without any underlying evident neurological or medical cause. Okay, that's mean just the patient or the child is walking in toes, but on examination and history taking, we couldn't find any real cause that explain this tiptoeing. So that's why it's called idiopathic toe walking. Sometimes there is a cause, but we couldn't reach it. We cannot reach it. It is very normal for toddlers at the start of walking to intermittently walk on toes. Usually, this persists up to 6 months after starting walking, may persist up to 2 years, but later on, or if it persisted more than this, then we can call it starting to diagnose the idiopathic toe walking or to search for a cause. But within the first 6 months after onset of walking, if there is no clear medical cause, then this is considered to be a normal development milestones in children. What is the etiology of idiopathic toe walking? Then again, idiopathic toe walking is walking on toes with lack of the heel strikes without any evident cause, without any evident medical cause. It's referred to autosomal dominant pattern, inheritance. It also may be secondary to abnormality of the types of fibers of the muscles. Sometimes it's secondary to sensory processing and sensory integration and sensory difficulties. And some refer to early use of walkers, the infant walkers. Early use of walkers may encourage the development of toe walking. So idiopathic toe walking usually starts with the onset of walking. So it starts below the age of 2 years of age as a variation of normality, as we told you, that it may persist normally within the first 6 months of life, but if it is of walking, but if it persisted later on, then it is a pathological condition, usually intermittent. That means the family tells you that the child intermittently to walk on toes, but he can also walk on heel, and he has a normal heel strike most of the time, or intermittently have a heel strikes, but most of time is walking on his toes. If the child is ordered to walk on heel, he can correct himself and walk on heel comfortably without any difficulty or without any deformity. Then we have to ask about the presence of family history, because family history may be positive, and the same condition may be present as a past history for the mother, for the father, or other sibling of the family. But we cannot say it is an idiopathic toe walking without thorough neurological examination and orthopedic examination to exclude any real cause of tiptoeing. And in this case, it is not an idiopathic toe walking. If the child is accustomed to uh, walking in toes, and if it is persistent after the age of 3 years, usually it became persistent, and usually there is no intermittent heel strike, and most of the time the child is walking like a ballerina, walking on toes. But the natural history has been mentioned in the literature that it may resolve spontaneously as late as 8 or 10 years of age. Okay, so it may persist for a long time, but uh, uh, at the end, it resolves spontaneously. This is an example of idiopathic toe walking. The child has no heel strike, but when he is asked to walk normally, he can walk very normally with the normal heel strike without any deformity of the knee or any deformities of the foot. It's very rare to have a unilateral tiptoeing, idiopathic tiptoeing. Once you see idiopathic unilaterality or asymmetry, then we have to think of a cause. Most of the cases, or the majority of the vast majority of the cases, will have a real cause. So it is not idiopathic toe walking. So presence of unilaterality is an indication for further investigation. So as we told you, the natural history of idiopathic toe walking will spontaneously resolve up to the age of 7 to 10 years. It does not result in significant functional disturbance or foot deformities or pain, and does not produce ankle contractures. So the concept that persistent toe walking will end up with a shortened Achilles is not really true and has not been proven in the literature. And there is no evidence that without any real cause, when the patient has only idiopathic toe walking, this will not produce ankle contractures or shortening of the plantar flexors. If the idiopathic toe walking does not improve over time with the maximum limit of 7, 8, or 10 years, then the patient will mostly have a neurodevelopmental disorders like autism-related disorders. So for diagnosis, 62% of patients with toe walkers have a neurological diagnosis. So only about 1/3 of what we see as an idiopathic toe walking without any cause will end up with a cause that will be discovered later on in life. So the diagnosis of idiopathic toe walking is the diagnosis of exclusion. We have to exclude all other causes before saying that the patient has idiopathic toe walking. So these causes, most of the cases are neurological problems, like the cerebral palsy or brain lesions or upper motor neuron lesions, spinal cord lesions, spina bifida, third core syndrome, neuropathies, hereditary neuropathies like hereditary sensory motor neuropathies, myopathies and diseases of the muscles and muscle dystrophy, movement disorders like dystonia, autism spectrum disorders and language disorder and intellectual disabilities. All these may be causes of tiptoeing, and in the presence of any of these causes, it is not termed as idiopathic toe walking. And lastly, the calf muscle disorder, like shortening of the calf muscles, either the gastrocnemius or the tendon Achilles shortening. The brain lesion, most common is cerebral palsy. Usually we know the patient has cerebral palsy by the history taking. There are the risk factors for brain lesion, hypoxia, neonatal problems, incubation for a long time, delayed normal milestones, delayed sitting, delayed crawling, delayed onset of walking. But what makes life difficult is that almost 50% of cerebral palsy patient has normal age of walking without delay of walking. These make life complicated and make diagnosis sometimes very difficult. Also, in the brain lesion, the patient may start early with walking plantigrade, but later on develop the presence, develop tiptoeing after development of the arch, because early the physiological flat foot may mask the presence of tiptoeing. Also, we have to put in consideration in the presence of unilateral tiptoeing the diagnosis of cerebral palsy. And in these cases, usually there is involvement of the upper limb. So we have to look for the function and posture of the upper limb. There is another uncommon cause of spastic paralysis of the lower limb and tiptoeing, which is called hereditary spastic paraplegia. It's totally different from cerebral palsy. It is a genetic disorder. There is a family history of 50%. There is no involvement of the upper limb whatsoever, so it's not spastic or cerebral palsy diplegia. And it is a developmental disorder, develops after the child has been normal for a while, and it is progressive in nature, rather than this in contrary cerebral palsy that improves with time. The spinal cord lesion, we have to think of the presence of spinal cord lesion, especially if there is unilaterality, abnormality at the lumbosacral junction, spina bifida, tuft of hair, if there is a spinal, if there is scoliosis or spinal dysraphism, upper motor and lower motor mixed lesion of the lower limb, if there is bladder and bowel symptoms and incontinence for urine or stools, and if there is back pain or tenderness. This may point to the presence of spinal cord lesion. One of the most common causes for tiptoeing in children is hereditary sensory motor neuropathies and peripheral neuropathies. And in these cases, there is usually severe muscle atrophy. Early, the deformity may be mild, but later on becomes severe. It's characterized by the presence of cavovarus or equinocavovarus deformity. It is form of lower motor neuron lesion, and there may be a positive consanguinity and positive family history. As I told you, also one of the important causes of tiptoeing is delayed motor milestones is the presence of muscle disorder like muscle dystrophies. If it is Duchenne, there will be calf hypertrophy. It's a form of lower motor neuron lesion. There may be family history in the siblings or consanguinity. And it is characterized by proximal muscle weakness that's diagnosed by the positive Gower sign on asking the child to stand from sitting position. He has to support his trunk by his hand on his knees. Another form of neurological disorder is autism spectrum disorder. And a good percentage of children who does not have a clear diagnosis for tiptoeing and has been assigned as idiopathic tiptoeing may be proven to have autism spectrum disorder accompanied by or manifested as language disorder, intellectual disability, hyperactivity. All these may point to the presence of autism spectrum disorder. The real orthopedic cause for tiptoeing, other than the idiopathic tiptoeing, is the shortening of the calf muscles. There is no hypotonia, there is no hypertonia, but there is shortening, congenital shortening of the plantar flexors. This may be shortening of the whole tender Achilles or shortening only of the gastrocnemius muscle. In these cases, the child walk very stable gait on tiptoe, but he can walk also and compensate and walk on heel and have a heel strike, although there is shortening. This is usually could be accomplished in presence of shortening of the gastrocnemius. The child is able to stand with the heel on the ground and they can walk few steps with the heel, with heel strikes, but for long walking or running or something like that, he cannot put the heel on the ground. But if there is the real shortening of the plantar flexor, if the child is asked to put the heel on the ground, sometimes he has to compensate by recurvatum of the knee to put the heel on the ground. So for diagnosis of or exclusion of causes for tiptoeing and for diagnosis of idiopathic toe walking, there are key questions. The age of walking. If there is delayed onset of walking, then there is a neurological disorder. Okay, the onset of tiptoeing since the start of walking, it may be physiological, maybe idiopathic, maybe secondary to any neurological cause. If it is developed later on in life after being normal, then we have to think of hereditary sensorimotor neuropathies, familial spastic paraplegia, autism-related disorders, myopathies. We have to consider bilaterality. Unilaterality point to presence of a real cause and not an idiopathic toe walking. If it is symmetrical or not, asymmetry is like unilaterality point to the presence of a cause. And we have to search for any evidence of weakness, trunk muscle weakness, proximal muscle weakness like myopathies, the presence of severe atrophy point to the presence of lower motor neuron lesions, hereditary sensorimotor disorders. And we have to ask about continence, which is usually disturbed in cases of spinal cord disorder. During examination, we have to check reflexes, hyperreflexia or hyporeflexia. Okay, but in idiopathic toe walking, there are normal reflexes. We have to observe the child weakness and standing from setting, search for any evidence of unstable gait, because in the children with idiopathic or real idiopathic toe walking, they have a very stable gait. They don't have any weakness or waddling or imbalance. So we have to look for trunk balance and we have to look for the upper limb. Any affection of the upper limb is not an idiopathic toe walking. There is a cause, and mostly this is a form of hemiparesis or hemiplegia or cerebral palsy diplegia. If we ended up with shortening of the plantar flexors, then we have to do a Silver's coil test to differentiate between complete or total shortening of the tendon Achilles or shortening of the gastrocnemius only by dorsiflexion of the foot with the knee flexion and knee extension. If we gain dorsiflexion with knee flexion, then it is gastrocnemius only. If it is fixed in flexion and extension, then it is shortening of the tendon Achilles. So we have an indication to refer for a neurologist. My advice for any child with a tiptoeing without any clear cause in front of you, we have to refer to a neurologist. If we have unilaterality, if we have a family history that may indicate the presence of hypoxia, brain lesion, long-term incubator, all this is an indication to consult a neurologist. Delayed motor milestones, history of delayed motor milestone, delayed sitting, delayed crawling, delayed walking, the presence of some deformities And the classic deformities like equinocabovarus foot or cabovarus foot is an indication to refer to neurologist for diagnosis of hereditary sensory motor neuropathies. The presence of severe muscle atrophy should attract attention. And the presence of or history of hyperactivity or autistic feature or difficulties in educations, difficulties in language development, all these histories or findings during examination are an indication to consult a neurologist. How to treat idiopathic toe walking? Again, idiopathic toe walking is the lack of heel strike without any evident cause. Really, there is no real treatment for these cases, and usually they improve spontaneously without any intervention. And we instruct the family to usually advise reminder. Usually we have to remind the child to stand on heel, to walk on heel, some physiotherapy, use of orthotics are prescribed, doing serial casting and casting to allow the child, walking casting, to allow the child to walk on heel and to develop a sensory integration between the heel and brain to encourage the development of the normal heel strike pattern of gait. There is insufficient evidence for the use of Botox and the producing weakness of the plantar flexor. In cases of shortening of the plantar flexors without any other neurological cause, then we have to do release of the plantar flexor. But if there is a neurological underlying cause for this shortening of the plantar flexor, we have another considerations and other calculations and other consideration in planning of management of these cases. So only what I'm describing now is the treatment of congenital shortening of the plantar flexors. If it is gastrocnemius shortening, we have to do release of the gastrocnemius aponeurosis only. And if it is shortening of the tendon Achilles, we have to do it percutaneous tendon Achilles lengthening by doing distal anterior cut of the anterior 2/3 of the tendon Achilles and proximal cutting of the medial 2/3 of the tendon Achilles. This is a minor surgery. Almost there is no scars, and the patient is put in a cast for 3 weeks, walking cast for 3 weeks, and then remove it. This is a child with congenital shortening of the tendon Achilles. Look, she has a very stable gait, and here it is after doing release, normal gait pattern, and without scars, just a very small scar, 2 scars of the over the heel cords. So to take home message, idiopathic toe walking is walking without any detectable cause. We have to search for underlying neurological cause before diagnosis. So the diagnosis of idiopathic toe walking is a diagnosis of exclusion. The natural history is that it will resolve spontaneously up to the age of 7 to 10 years. This is the maximum limits mentioned in the literature, and it does not produce shortening of the plantar flexor if it is a real idiopathic toe walking. And if it is persisted, this indicates the presence of some sort of neurodevelopmental disorder. Thank you so much.